Welcome to my talk on Myhre and syndrome and its effects on sleep and lung. Um, Now, I do have some conflict of interest that I need to share with you. I work on therapeutics directed at Duchenne's muscular dystrophy for selective pharmaceuticals, and I'm co-PI on a gene therapy program on Canavan's disease, all of them focused on correctors of genetic disorders. Now, Myhre, as you know, is a SMAD4 gain of function mutation, and which is central to TGF signaling, which leads to things that affect the lungs very obviously: scarring, short bones, contractures, and developmental concerns. All of these have particular implications for the lung and sleep, of course. The thing we'll start the lungs first. The item that's most concerns parents is airway stenosis. And a lot of it springs from a number of core cases that have been published over the years. Now, this case in particular, this is the airway going down like this. You see narrowing here at the mid of the, that is the trachea here, the main airway. And then you see narrowing here going off to the left-hand side. So on the whole, now this is probably related to an airway that has been instrumented in some way. However, we don't see it very often. Indeed, we haven't seen it at all. Now, we worry about this, but we just don't see it. Now, it is very easy to find. It's very easy to find by doing pulmonary function testing. Now, this is a normal pulmonary function loop in somebody early in their years. And then as they develop narrowing of the airway, in this case, subglottic stenosis, you see it becomes more flatter. And we call the peak flow rates go down. Now, it's very obvious. It's very, very obvious. So it's very easy to pick up. Now, we have, when I did the review last year, we had 42 cases. We have not seen a single case. We've not seen a single case. However, we do see this, and we've done a number of CAT scans on the airways, and you see what we call airways of hyperinflation. Now, if this is a child, this is here, as you'll see, as we go up and down. It depends how the CAT scan's cut, but generally this is the left side, right side, and you see the grayness here, and then you see this area of hyperinflation, see this area of darker. Now that's probably from some airway narrowing in the small airways low down. Now we saw 6 out of 23 cases. The CAT scans are not optimized to find it, but because very small areas of lungs are affected, it has no physiological consequence that we see whatsoever. And most children have no idea that they have it. The other feature that we do see is restrictive lung disease. Now, restrictive lung disease means the lungs are small. Lungs are small. Excuse me, putting my picture earlier. Lungs are small. Now, we measure a thing in lung functions called forced vital capacity, and that means how much air you can force out of your lungs. And it gives you an idea of size. And this is FEV1, how much you get out in 1 second. Now, usually these are 100%, and you can see in this child with Myhre syndrome, they're 58, 62. Okay, 58. This is, now, we had 8 children who had CT scans and PFTs, pulmonary function tests, and the average forced vital capacity was 67%. 2 of them, although in this part of the study, had hyperinflated areas. The restricted pattern here was not explained by lung disease. That means scarring within the lungs. There are many reasons for small lungs, as in this case. Lungs are small because the development didn't make them big, so they were made small. The other reason is the rib cage is small, or this is interstitial lung disease where you get diffuse fibrosis of the lungs. And indeed, the latter we just don't see. Now, the concerns about the latter being the interstitial lung disease was mainly from the STAR study, and they have a case. Where they took this is a biopsy and pathology of the lungs. Now, these are the alveolar sacs here, and you can see the area between this sac and this sac is thick. Now, it's supposed to be very skinny, maybe like this one down here. So these are very thick, and that's called interstitial lung disease. Now, this is the case 2 from the STAR study. And then there's another case from South Carolina. Now, we have reviewed 23 CAT scans and have not seen it. So it may, for this to happen, you may have to have Myhre syndrome combined with a big viral illness. And even there, we're not seeing it. Because we've had a number affected by COVID and just not seeing the scarring. So on the whole, we think this is a rare complication of Myhre and less concerning. We do see the thick ribs. Now, these are the chest x-ray. This is left, right, and this is the heart. Okay. Now, here you see the thick ribs here. You see the thick ribs here. Now, on all 23 CAT scans, there was increased thickness of ribs. Now, this is very subjective, but it was generally there. Now, we do see it in other sort of storage disorders. So now this is likely to be contributing to the small lungs. Now, we also think the lungs are small. Now, these lungs are small. It begs the question. Now, they all look small on CAT scan, and you can see how this is small compared to chest wall. Now, is the defect the lungs were made small or the chest wall is constricting? So I'd like to be a combination of both, to be honest. So make a long story short, we do see restrictive lung disease, which means small lungs. It is common, and the lungs are now, but we do not see true interstitial lung disease. And even if we saw true interstitial lung disease, the future is bright in this area because we now have therapeutics that should work very well in SMAD4 mutations. Okay, could this interstitial lung disease develop later? Possibly, but we're certainly not seeing it so far. Now, I think the other issue that's very important to recognize, when the capacity of the lung is amazing. If you have 50% function, you're going to do fine. You certainly won't go to the Olympic Games, but you may not even notice that your lung function is down. So the capacity is great. So even with these lower numbers, there's not a major concern. What we do see, and most of our patients who come to see us in clinic want to talk to us about sleep. There are 2 aspects that we see to see it: the insomnia and the obstructive sleep apnea. Now, just talk about the insomnia first. This means that this is just a graph, and sorry about the haziness of it. As you get older, you sleep less. So if you start out sleeping, 14 to 17 hours as a baby, and then we get to 65, 78 hours or more than fine. Okay. Now, it was well known prior to this that people with autism spectrum disorder have shorter sleep cycle. Now, this is looking at shorter sleep cycle, and see how it's shorter here in red, and this is the control. Now, this graph hides some of the facts here, because some people with autism spectrum have normal sleep patterns, and others are completely dysfunction. They're all mixed in together. So this is very common. It affects the majority of patients, so a short amount of sleep, and you can sleep as little as 5 hours. Now, we looked at it constructively. Of 14 of the 19 patients had it. Okay, that means they would sleep for about 5 hours a night and are totally fine and get up. And it's difficult to treat and very disruptive to families. Now, it's going to function that, they're not going to be great if they're getting by on 5 hours of sleep. Their behavior is not great. Melatonin and trazodone were central to this. Okay, the center of this. Other drugs that we use to treat this is clonidine if we had ADHD, so the combination is great. Hydroxyzine, which is Atarax, which is an antihistamine. This is great if you have anxieties. Now, these we talk about a bit, but we don't use them very much. But what I do want to point out is a very, very important change. There's been new medications to deal with insomnia in the last year. Now, they're approved down to 12 years of age and likely to go lower. And it's called So or Veraxant. Now, better known as the name is Belsomra, so nice sleep, Belsomra, which is called a receptor and orexin receptor antagonist. And you might say, what has this got to do with anything? Well, this was first defined because these receptors were found to be mutated in dogs who had narcolepsy. And that narcolepsy means they had a mutation that knocked out the receptor and the dog would fall asleep. And that's what narcolepsy, you could fall asleep in anything if you have narcolepsy. Okay. And then ultimately, they went on to develop inhibitors of receptors so it behaved like the dog. And clinical trials demonstrate to be safe and effective. Now, it's pretty impressive how effective this is. Now, lots of the other medications that we use for sleep have tremendous side effects, but this one seems to be very, very good. So I do think the future of these type of medications are going to take over from trazodone. And just getting it approved has been a challenge, but it's definitely getting there. Now, the other thing that we see is obstructive sleep apnea. And the main reason is because there's facial features that reduce the size of the airway. Okay, obstructive sleep apnea just means you stop sleep, you stop breathing for short periods of time, and you snore. Now, it's associated with the risk of further developmental delay. So if you can't sleep well and you've been apneic all the time, then it's a problem. It also increases the risk of heart disease and stroke later in life. Now, 25% of our patients had sleep studies, and it was certainly there. It's not well documented. It's not well documented. So an aspect of sleep that you'll see as more and more investigation, it's something that we're behind on in the study of Myhre syndrome. Now, this is what a sleep study looks to us. We look at these things called apneas, where you stop breathing, and this means this is stop breathing. You see your chest wall is not moving down here. You stop breathing. This means this is obstructive apnea, and that means your chest is trying to move it, but no air is going in and out because your upper airway is obstructed. So this is what you see. Now, the sleep studies are very helpful at finding these. And we measure out this thing called apnea-hypopnea index. Okay, and these are certain numbers we use. 1 to 5 is mild, 5 to 10 is moderate, and then greater than 10 is severe. Now, apnea means periods where you stop breathing and periods where you shallow breathe. So these are very, very important numbers. Now, when we see people, and I'll just march through this a little bit, when we see people with this, we look for reasons why you're obstructing your breathing. We look for allergies in your nose. Okay. We look for things like a small palate. Now, remember, a small palate is very important because the palate has to contain your tongue, your tonsils, and if it's small, then we have to do something about it, like a palate expander. And these, believe it or not, you see this thing back here, this is your adenoids, okay? This here is the tonsil. This here is the tonsil. So adenoids, tonsils. So we look for all these things. Do you have allergies in your nose? Do you have a small palate? Do you have big tonsils or adenoids? And if you have big tonsils and adenoids, the bottom line is we take them out. Now, adenotonsillectomy is very effective for obstructive sleep apnea. In children with Down syndromes, it's 82% effective. But it's even in those with syndromes, it's likely to improve the situation quite dramatically. And even with the risk of scarring, it still would be your first choice. Do it your first choice. The second choice, which is always hard to do in somebody who has autistic features, after that, is a palate expander. Well, we know with Myhre syndrome, they have a very small palate, and that's part of the problem. So these palate expanders can be very effective. Now, this just shows, and I'll just march it up here. This means that you just put it in, and you can see the apnea-hypopnea index is 12, which is severe. And as you expand it out, it goes down to less than 2, which means it's in the normal range. So this is actually from one of my patients who had a palate expander. Now, the other things that we do, and we just don't do this with Myhre syndrome, is we advance the jaw with advanced surgeries. Now, this is becoming more and more progressive and more an important issue. Now we do it now. Other syndromes that have a small jaw is called Pierre-Robin syndrome. And now what they found in these sort of patients, 97%, 100% of adults with small jaw were cured of their symptoms. Now this may be less of an option because with Myhre syndrome, because of the risk of scarring. And so what you have to do is you have to put a nick in the jaw and move it forward slowly. So this one it's a possibility, but we have not got there yet. Now, and then final option for us is to do CPAP. Now, CPAP is where you wear a mask. You're familiar with it in adults. And it's not very well tolerated in Myhre syndrome because of the fit on the nose of the mask. So all in all, it's less of an option. So if you have obstructive sleep apnea, we do start with tonsils and adenoids, and we do start with the palate expanders. And before we will go to CPAP or jaw advancement surgery. So even though the surgery sounds crazy, most patients like it. Most patients like it. So guys, to make a long story short, thank you for listening to me, and I appreciate you watching this lecture, and look forward to meeting you in person. And look forward to enjoy. I hope you enjoy the rest of the sessions.